Okay, sir. We are live now. I'm starting.
Yeah.
Very good afternoon and warm welcome to all the dignitaries present here. I am Momita from Clinic, serving as the allocated session assistant to ensure a seamless experience. Clinic stands as India's most relied upon digital platform offering a multitude of imaging services exclusively for doctors. It is with great pride that Clinic serves as a digital partner for this event hosted by the National Neonatology Forum Gujarat. And the focus of today's session is case presentation, Tracheo, Oesophageal, Fistula. So let's begin today's session for which I would like to invite Dr. Kunal sir to take over. Over to you, sir.
Thank you, Momita. So today we are having a case presentation as we are continuing with the case presentation series. So today we have with us Vaishali, who is doing her fellowship, and for our experts we have Dr. Shilpa Kalane ma'am, where I worked with in KEM. So happy to see you, ma'am. We have Maulik Shah sir also with us. We have met last month only, and we are regularly meeting also. We have Dr. Vijay with us, who will be moderating our session. But to start with, I would request Shwetal ma'am to say a few words. She is our president of Gujarat State NNF.
Thank you so much, Dr. Kunal. With going ahead with the case series, this time we have invited a fellow in neonatology who are exam going, so they can get a prelim exam or a rehearsal, they can do it. And thank you so much, Dr. Shilpa and Dr. Maulik, for being an expert faculty for that. Thank you.
Thank you so much for the kind introduction.
Vijay. Dr. Vijay.
I
Yeah.
think he's
I'm
not
audible?
connected.
Hello.
Yes, you are audible.
Yes.
Okay. Thank you, Kunal bhai and ma'am. So I welcome all of you on today's neonatal Pathshala. And today we have a case presentation of tracheoesophageal fistula, and it will be presented by Dr. Vaishali Chaudhary. She is fellow in neonatology at Arpan Newborn Care Center, Ahmedabad. And with her, her mentor is Dr. Vishal bhai. Dr. Vishal bhai is a consultant neonatologist at Arpan Newborn Care Center, Ahmedabad. He is also visiting fellow in neonatal ECMO at Leicester, UK. Dr. Vishal bhai is also faculty for various neonatal training program and various national as well as international conferences. So I welcome Dr. Vishal bhai. For expert, we have two expert today. One is Dr. Maulik Shah sir. Sir has almost 20 years of experience in the field of pediatrics, and sir is a professor of pediatric and in charge of Sikh newborn care unit at GJ Government College, Jamnagar. Maulik sir is also faculty for various neonatal training program and conferences. One more important thing is sir has made more than 200 educational videos with more than 9 million views for that. So I welcome Maulik Shah sir. And another expert we have Dr. Shilpa ma'am. She is a chief neonatologist at Dinanath Mangeswar Hospital, Pune. She is guide as well as examiner for various neonatology training program like DNP Neonatology Fellowship Program. She is also faculty in many national and international conferences. She has more than 40 publication in Index Journal. And ma'am is also joint secretary at Maharashtra State NNF. So I welcome Shilpa ma'am also. So now I request Kunal bhai to please allow Dr. Vaishali to go ahead.
Yes, please. Vaishali, you can start sharing your screen.
Yes, sir.
Good afternoon to all teachers. So today we are discussing a case
Vaishali, you can make it full screen.
already in full. Uh, uh,
પ્રેઝન્ટેશન મોડમાં જાઓ, થઈ જશે. નીચે જે પીપીટી સ્લાઇડ્સ આપણે પ્રેઝન્ટ કરીએ ને એમાં પ્રેઝન્ટેશન મોડમાં જાઓ. ઝૂમ નથી કરવાનું.
What you can do,
નીચે
Vaishali? Yes.
નીચે પ્રેઝન્ટેશન જે દેખાડતું હશે અથવા ઉપરથી પણ કરી શકશો.
Already doing
Slide show.
same thing, but it is not working.
What you can do, Vaishali, is unshare your screen first. Yeah, now it is visible. Yes.
So good afternoon to all teachers. Today we're discussing a case of esophageal atresia with tracheoesophageal fistula. We are talking about a newborn baby with gestational age of 34 plus 4 weeks, birth weight of 2.9 kg. Mother was the third gravida with history of previous two abortion. Mother was known case of diabetes mellitus, was on insulin, which with an HbA1c of 6.5%. Antenatal scan was suggestive of polyhydramnios. Baby was born out of elective LSCS. At the time of delivery, baby had breech presentation, cried at birth. Apgar score of was 8 and 9 at 1 and 5 minutes. After the initial stabilization, when tried, feeding tube could not be negotiated for the desired length from the mouth. On examination, as such, there were no other major apparent malformations or deformities. Rest of the general and physical examination was normal at birth. So
Vaishali,
patient, yes, ma'am.
can we ask questions or
Yes.
Yes,
Kunal?
ma'am. You can in between ask questions.
Okay. Go back to the history, your previous slide.
Yes, ma'am.
So 34 plus 4 weeks, baby girl, baby boy,
Male child, ma'am.
male child. Okay. So what do you think, Vaishali, if the mother has diabetes during pregnancy, what would be the impact on the baby?
Uh, Baby can have various complications, such as baby can be macrosomic. There can be polyhydramnios. There can be various congenital malformation, including neural tube defects as well as cardiac malformations. In the neonatal period, baby can have respiratory distress. Baby can have hypoglycemia. Can have polycythemia.
Okay. So tell me, when the mother is known case of diabetes and is on insulin, and when the baby mother is diabetic and is on diet, just control on her sugars are controlled on diet, would there be any difference in terms of the neonatal outcome in both scenarios?
As long as, ma'am, HbA1c is concerned, if it is more than 11, there are more chances of congenital malformation. If it is well controlled, the glycemia, normoglycemia is there, and HbA1c is around 6, then chances of malformation are less.
So
Very
yeah,
good. Vaishali, can you tell us
yeah.
few common congenital anomalies associated with a mother in an infant of diabetic mother?
Okay, sir. For the for the CNS malformation, there can be neural tube defects, including sacral agenesis, which is more common. Then there could be spina bifida, and all. In the cardiac, there could be ventricular septal defects. There can be transposition of great arteries. There can be hypertrophic cardiomyopathy.
Okay. Since the mother is having diabetes mellitus, she is on insulin. Would you please like to elaborate specifically related to White's classification of maternal diabetes and the fetus?
Sorry, sir. Can you repeat?
When the mother is having diabetes And usually in the perinatology, since we are taking a case from a fellow, we expect a little more than what postgraduates know. So, do you know White's classification for diabetic mother? Okay, let's move forward. Yes, ma'am, you can ask.
You mentioned about polyhydramnios, Vaishali. What is polyhydramnios?
Uh, there is increased amount of amniotic fluid.
Yes.
Antenatally, they measure, they divide the whole amniotic sac into the four quadrants, and the sum of the or deepest vertical pocket in the all four quadrants, they add up to make amniotic fluid index. When amniotic fluid index is more than 25, usually they labeled as polyhydramnios.
25 or more than 25.
Yes.
Any other definition of polyhydramnios?
Um,
Okay. Tell me three causes of polyhydramnios.
Ma'am, one is in diabetic mother. It can be congenital malformations related to gastrointestinal tract, like intestinal obstruction, where the fetus cannot
Okay.
swallow the amniotic fluid. Uh, uh, there could be congenital viral infections, uh, hydrop, fetal
Congenital,
anemia.
congenital viral infection leading to polyhydramnios? How?
Can you explain it?
Uh, मतलब in case of congenital viral infection, which lead to fetal anemia, uh, they can lead to, due to anemia, they can lead to CCF and lead to hydrops and polio.
That explains hydrops, not polyhydramnios. Right? So, which are those things which you have still missed in the possible causes of polyhydramnios? Anything which is ventral? Have you heard gastroschisis?
Yes, sir.
Okay. Have you heard omphalocele major?
Yes, sir.
Can they have polyhydramnios? Yes, they can.
Yes.
Okay. Fine. Let's move
So,
ahead.
yeah. So, whenever you are asked about the causes, it's always good to divide the causes. Like, polyhydramnios, maternal cause, placental cause, and fetal cause.
Yes.
You may not have to remember all causes, but two causes, at least in each category, you should be able to answer. Okay. And
Okay.
talk about the most common cause and the rarest cause. Right?
Okay, Vaishali, whenever you are scanning and a perinatal reference has come with the polyhydramnios in the particular baby or
Yes.
the in utero baby, what is your emphasis specific related to a stomach bubble? Visualization of stomach bubble says us what? And if it is not visualized, what does it say?
Okay. Um, Visualization of usually if a stomach bubble is small or absent, there can be a possibility of esophageal atresia.
Okay,
And if it is present also, there still can be chances of esophageal atresia, along with if the child has, if the baby is having type C fistula, then fluid from the lung can move through the fistula to the stomach, and then they might have stomach bubble apparent.
okay. So ultimately, it helps in typification or staging of tracheoesophageal fistula.
Yes, yes.
Thank you.
So tell me, if this mother comes to you with the report saying that so the AFI is around 28. This is a
Yes, ma'am.
34 weeks gestation,
Yes,
breech
ma'am.
presentation. Nowadays, scans we know which it's vertex of breech
Yes,
presentation, right?
yes.
And absent stomach bubble.
Sorry,
Okay,
ma'am.
so
What about
absent
stomach? Absent.
absent
Okay,
stomach
okay,
bubble,
okay,
right?
ma'am. Okay, ma'am.
So how would you like? What would be your differential in this case? It would be only esophageal atresia, or are you going to think about other differentials as well? So, in short, absent stomach bubble with polyhydramnios. What are the other causes? Why the baby should have stomach bubble?
If there is fluid present in the stomach.
So whenever there is swallowing, there has to be a stomach bubble. When the
Yes.
swallowing is not there, then you will not see stomach bubble.
Yes.
So in which all conditions swallowing would be affected? One is esophageal atresia.
Yeah.
Which any other condition?
Any neurological condition where baby cannot
Perfect.
swallow.
Yes. Even in syndromic baby neuromuscular cases, you may get these findings. Okay. Typical triad, breech presentation, polyhydramnios, and absent stomach bubble or small stomach bubble. Okay.
Yes, ma'am.
Yes. Please go ahead.
Okay. After initial stabilization, when tried, the feeding tube could not be negotiated for the desired length from the mouth. On examination, as there were no other major external malformations or deformity. Rest of the general and physical examination was normal at birth. So patient was shifted to an
Stop. What do you mean by initial stabilization? What is after initial stabilization?
uh, so after the birth, as baby cried immediately after birth, there will be drying of the baby, routine care, and then we'll go to the general any look for the any external malformation in the baby.
No. So you need to talk about delivery room details, the resuscitation details. It cannot be after initial stabilization. You have to talk about all points here. Okay. What? One
Vaishali,
thing you. Yes, sir.
Vaishali, can you tell us very briefly about the three different cares which are supposed to be given in a resuscitation? One is called routine care, second is called observational care, and third one is post resuscitation care. How do you differentiate all of them, and what are the essence of them?
Uh, uh, in the routine care, as baby has cried immediately and stable, then we will ensure warmth, uh, routine drying, and maintain euthermia. Uh, then initially with delayed clamping of the cord and giving of vitamin K at the birth. This will be routine. Uh, then post resuscitation, uh, in the post resuscitation care, uh, the baby will be transported to the NICU, ensuring euthermia. And if the baby is very preterm and any need for respiratory support,
Very good.
better to give the delivery room CPAP and transport on the some positive pressure ventilation to the NICU.
If we want to give some temporal time frame to this, uh, how many minutes you would like to put something?
Sorry, sir.
According to the NRP classification, the routine care is offered to these babies who you have said that they have started breathing and other things, right? But
Yes,
as
sir.
per the time frame, if we concern, then how do you differentiate both of them? Observational care, post resuscitation care, like that.
Uh,
Okay. If it is less than 1 minute, the baby still remains with mother, but under the observation of physician. That's why it's called observational care. If it is more than 1 minute of resuscitation and the baby is found to be asphyxiated, the baby goes to an NICU under the neonatologist care. So that is the basic hallmark or the difference of the two cares,
okay.
right?
Yes.
In routine care, the baby is always with mother. Okay, thank you.
So you've written here that the feeding tube could not be negotiated for desired length from mouth. Can you clarify this? What is this desired length from mouth?
Uh, Usually, for feeding tube to be present in the stomach and confirm the position, we measure the length from angle of the mouth to tragus and to the epigastrium.
So there is a
It's
specific
not
length.
epigastrium.
10
So the
centimeter or more.
10 to 15 centimeter. If you are not able to negotiate beyond 10 to 15
Yes.
centimeter, you have to think about atresia. And what do
No,
you mean by
still you have to give me the last point of insertion. You have given me two correct points that from the angle of mouth to the tragus, and what is the end point in the stomach? What is the landmark you are going to see? It's a midpoint between
Xephisternum and
and
umbilicus.
yes?
yes. So that's the 3 point thing what you have to tell us when we talk about the desired length of a tube.
And can you clarify on this? Rest of general and physical examination was normal at birth. What exactly do you mean by what exactly are you looking after for here? Now you know you're dealing with esophageal atresia.
Yes.
So what do you want to rule out by general and physical in general and physical examination?
In the general examination, any other external anomalies will any look for midline defects, such as if there is a wide open AF, anterior fontanelle, can protrude, point towards
Can you be a little more specific?
wide open AF that can point towards congenital hydrocephalus. Then we'll look for cleft lip palate.
No. I'm asking about the anomalies related to esophageal atresia.
Okay, ma'am. We'll examine for back end. Okay. We'll look for the limb anomalies. As there can be association with the vectoral.
What are the parts of actor?
Vectoral stands for, ma'am, vertebral anomalies. Anogenital malformation, cardiac anomalies, tracheoesophageal fistula, renal, and limb anomalies.
Any other association or syndrome you want to rule out?
There could be association with uh, trisomy 21, Down syndrome,
What about
trisomy.
charge syndrome?
Yes, ma'am. Also with the charge syndrome.
Right? So that is
Yes, ma'am.
more specific, right?
Yes, ma'am.
What do you think is the overall incidence of associated anomalies in cases of tracheoesophageal fistula? If I see a patient with tracheoesophageal fistula, what is the percentage that the baby is likely to have other anomalies? Any idea?
Around 10%.
Any other number? Around 50%. Okay, so we have to do. And when you see these patients' cardiac examination, what specific things you would like to know? Like maybe later on we'll ask about this. Okay, so when you write or when you present, it's don't say rest of general and physical examination was normal at birth. I want to know I know that you know this case is aspirator, so I want to know specifically what are you looking for here. Okay. Yes. Next.
Okay. So patient was shifted to NICU. On admission at the NICU, patient developed increased drooling of the saliva as well as increased respiratory distress. As they developed a significant respiratory distress with an downward score of 6, patient was intubated and kept on mechanical ventilation.
Okay,
What
just
do you
at that
think?
point,
Yes, sir.
what are the differential diagnoses which comes to your mind when a patient comes to an NICU with drooling of saliva and respiratory distress?
Uh, first of all, the esophageal atresia, then the same where any neurological condition where patient cannot uh, swallow or they can
Be
they can
specific, be specific. Any
uh,
neurological doesn't make any sense.
uh, if there is a birth asphyxia or encephalopathy.
I think we are looking for more specific things from fellows. Okay, fine. From neurology, which are the other things which you would like to see? Let's keep neurology aside. One, you have said tracheoesophageal fistula. Second, we believe that there is encephalopathy, and because of that, there is some problem. Fine. What else can present as drooling of saliva?
Uh, if there is facial palsy,
Why facial palsy should have a drooling of saliva as good as what tracheoesophageal fistula gives? Fine. Okay, move ahead. Ma'am, you want to ask something?
Yes. Okay. I think we uh, proceed, Vaishali.
yes. Baby was kept on assist control mode of ventilation with FiO2 of 30, PIP of 20, PEEP of 5, frequency of 40, night time of 0.4. Umbilical venous catheter was inserted. Position was confirmed in the USG and X-ray. Patient was started with IV fluid and sedation. ABG analysis showed mild metabolic acidosis. Blood culture was sent
Stop,
and for
stop. Can you read that ABG?
ABG showing pH of 7.29, PO2 of 83, PCO2 of 42, bicarb of 19.7, and base excess of minus 6.
Why do you think this is metabolic acidosis?
As there is pH is 7.2 and bicarbonate of 19.
What is normal bicarb in a preterm baby?
Uh, for uh, 20 to 22.
20 to 22? This is acceptable, okay? And when you have all the numbers normal and the pH is on lower side, it could be because of heparin also sometimes, right?
Would you like to comment upon the PCO2?
Absolutely.
PCO2 is yes, from 45 to 55 is normal. It's slightly on lower side.
That is permissive hypercapnia, ma'am.
Yes.
We are
But
not talking about permissive hypercapnia here.
absolutely. This is at birth, no? At birth, why do we talk about permissive hypercapnia? This is birth. This is normal, right? But on a higher side or lower side. Normal PCO2 is 35 to 45.
35 to 45. This is
Correct?
on higher side.
This is acute setting. The baby is not, we are not talking about BPD here. This is acute. The baby, you just ventilated the baby, right?
Yes.
Okay. And I just want to know one thing, that this baby got ventilated. If this baby wouldn't have got ventilated, what would be your plan of management?
If a patient is not having this respiratory distress, then there will get an chest X-ray done.
No. When we talk about management, we talk about clinical management. Investigations last.
Okay.
Clinically, we know this is esophageal atresia. You're facing problem with the drooling of saliva.
Yes.
Correct?
Yes.
How would you manage this patient in NICU from the time of admission?
As there is risk, as suspected tracheoesophageal fistula or esophageal atresia is there, there are chances of aspiration of the secretions, the saliva. So will ensure that the nasogastric tube can is inserted into the and through that we can make continuous suction, intermittently suction out this.
Okay.
So, was it an elective intubation?
Uh, yes, मतलब respiratory distress with a Downey score of 6. So yes, maybe he was intubated.
Okay.
Vaishali, you've told only half of the story. The baby is not ventilated. This is a very common situation. When baby getting ventilated because of esophageal atresia is not a common situation. Okay. So if if the baby has esophageal atresia and doesn't get ventilated, how would you manage in an ICU? I understood your worries, but tell me, how would you prevent all those complications? How would you manage that patient in an ICU? One, you said suctioning.
Yes, prevent aspiration of the secretion,
Hmm.
and will keep watch on if the baby develops any respiratory distress.
Anything else specifically for esophageal atresia?
To prevent still aspiration other than suctioning out, we'll keep baby in the lateral position so that if any by any chance secretions are there, they not might not get aspirated.
So head high and prone
Yes,
nursing,
head up. Yes,
right? Head
yes,
up, prone
Have you?
nursing, suction.
yes.
Yes. Vaishali, have you heard about the Replogal catheter?
Uh, Maybe it is used short length catheter used to put into the atresia pouch that can continuously suction out the secretion.
Yeah, it helps out and it takes away your pain of recurrent suctioning of a particular pouch. So if you insert a Replogal catheter, that solves out many of the issues related to the tracheoesophageal fistula,
Oh,
especially the aspiration.
yes.
Go ahead.
Uh, so the umbilical venous catheter was inserted, which was confirmed in the USG and X-ray. Patient was started with IV fluids and sedation. EBG analysis and the blood culture was sent. First line antibiotic was started. Initial workup in the CBC and calcium was normal. uh, Chest X-ray was done, which was showing coiling of the feeding tube at the T4 level, with gas shadows seen in the stomach. So finding probably suggests esophageal atresia with tracheoesophageal fistula, probably type C.
Why probable esophageal atresia now?
Yes,
You're
it is
showing the
confirmed.
X-ray, you're talking about coiling, you're talking about difficulty in passing the tube. Now, why probable?
No, ma'am. We can confirm with the X.
She is making probability of type C.
Okay. Okay.
So, to rule out any other associated anomalies, 2D echo was done, which showed no structural anomaly and then normal ventricular function. USG abdomen and KUB was done, which shows normal USG. USG head was also normal.
Just a moment. In this particular X-ray only, what other anomalies you would like to rule out, which are commonly found to be associated with a tracheoesophageal fistula? So while looking at this particular X-ray, I would also like to rule out 1, 2, 3 like that.
Sir, if there is vectoral association is there, we can see any vertebral anomaly like fused vertebrae or hemivertebra. Um, then uh, uh, any cardiac anomalies if uh, with by looking at the size of the heart shadow. Uh, any if gas is not passing till the end, then we can also suspect any anorectal malformation.
On this X-ray?
Okay.
Or you
No,
want special type of X-ray?
yes, ma'am, it can be invertogram. Cross,
So more than invertebral lateral decubitus X-ray, right?
yes.
We- yeah. Okay. So why was
Ultimately, what
echo?
you can say is a normal gas pattern or a normal bowel pattern. So it just says that there is a possibility that there is not likelihood of any cloacal abnormalities or any other.
Actually, what was the birth weight you mentioned?
2.9 kg.
For a 34 weeker, do you feel 2.9 kg is good weight?
Uh,
What was
no, it
as
was large for it.
it was large for gestation? What percentage of the baby's weight was poly?
98, ma'am.
What are the causes of large for gestation age baby?
It can be infant of diabetic mother. It, there can be uh, some syndromes where are like with Weizmann.
Okay.
Uh,
Was this baby edematous at birth?
uh, no, ma'am. There can be hydropsis also.
No. Was this baby edematous? Because this
No,
X-ray is showing some skin thickening.
no, ma'am. There was
Plus
no,
polyhydramnios. No. Okay.
no, ma'am.
Okay. Why was echo done in this case?
To rule out any vectoral association, cardiac anomaly.
Any other cause? I'll send
As the
Cadbury from
patient,
Pune.
sorry,
I will send Cadbury from Pune if you tell me the reason why we should do echo in patients with esophageal atresia.
patient will be posted for surgical procedure. So preoperatively, we have to uh, rule out any cardiac.
Any other specific cause, specific thing which we look for when a patient is getting operated for esophageal atresia? What do we see? What does your cardiologist report when he or she also knows that the baby is a case of esophageal atresia? And if they don't look for it, then we have to catch them and ask them, have you seen this? The arch of aorta.
Okay.
Why is it important?
So in the surgery, when they do thoracotomy and we
Correct.
repair, they have to approach from the side. The If the aortic arch is on right side, well, they have to decide on side from.
Absolutely, absolutely. So if they don't know and suddenly when they do thoracotomy and they come across an arch, then it's a problem, right?
Yes,
So the cardio 2D echo is for structural to rule out structural anomalies, but at the same time, very important if the baby is going to get operated, we need to know arch.
yes.
Okay, it's right-sided arch or the left-sided arch. Okay, yeah.
So preoperative workup was sent. This is normal.
Specify it. Don't use general
Preoperative
terms.
workup including the complete blood count, uh, PT and INR, uh, renal function test, and uh, HBsAg, HIV were also sent on.
So why HbSAg and HIV in this patient?
Uh, as there is a major surgery prevented.
This mother must
So
be
it's a
registered mother,
surgeon's
right?
demand or neonatologist need.
Sorry, sir.
This mother must be registered, no?
Yes, yes, yes.
So if she's registered, she must have undergone
Negative.
investigations. And if she's undergone the investigation, why would you like to repeat this investigation on a day one old baby? Or it's a protocol in your unit?
No, ma'am.
Or you're just saying?
As a part of preoperative workup, we could send.
No. So when it's a day one, day two old baby, not received any blood transfusion, correct? It's a neonate.
Yes,
Mother is registered, has been investigated thoroughly. Then we don't have to do pre-op HbS antigen and HIV.
yes,
Okay?
ma'am. Yes, ma'am.
Right. Yes.
So detailed counseling was done and consent was taken and patient was posted for fistula repair the next day.
What
Uh,
counseling was done?
Including the current diagnosis of the patient and possible the procedure and complication during the surgery as well as post-operative course of the patient uh, was explained to the patient and related.
What about complications?
There are various complications can occur even when the fistula has been repaired. Can occur esophageal strictures,
Okay. Okay,
esophageal.
okay. Okay, just proceed.
Okay, Vaishali, given a choice, what will be the exact time when you would like to schedule this surgery? Right at the birth within 6 hours, or maybe after, like in this case, on third day? What is your choice and why?
Uh, if a patient is stable, then we can initially do workup and rule out the association. And if the patient is matlab, having respiratory distress and can be posted sometime due to aspiration of gastric secretions and all. There is distension of the stomach occurs, which again can put the pressure on the lung and interfere with the ventilation. In such cases, babies may require immediate intervention.
But they say that the respiratory distress usually commonly occur because of the pneumonia which develops due to aspiration, commonly right upper zone. So why would you like to wait and let it develop? Why not right at 0 hours you go for a surgery?
Just initially after ruling out the we can definitely go and on day one of life itself.
Okay, most of the people nowadays in the world, diaphragmatic hernia or tracheoesophageal fistula, both are done with the elective way, stabilizing the baby, let the baby do well on ventilation and hemodynamics part. And once they are stabilized, if you do the surgery, the outcomes are better. That's what the evidence suggests us. So nowadays, no longer surgeries are being posted right at birth or on day one unless the baby is really well stabilized and surgeons are in hurry.
Proceed.
So, patient was operated on the third day of life. The procedure was right
Just a
postulated.
pediatric surgical perspective, when would
Yes,
you go for a left-sided thoracotomy?
as we discussed earlier, when aortic arch is uh, right-sided aortic arch.
Okay, fine. Go ahead.
Uh, so, right posterolateral thoracotomy was done with a ligation of tracheoesophageal fistula and end-to-end esophageal anastomosis was done. Intraoperative findings were esophageal atresia with blind upper pouch, lower esophagus opening into the trachea near carina. Feeding tube was inserted and secured, and ICD drain was inserted. Uh, Post-operatively, patient was on assist control mode of ventilation with the FiO2 of 21, PIP of 18, PEEP of 5, uh, frequency of 14, I time of 0.4. ABG was near normal. Uh, Post-operative workup was done, including CBC, CRP, and electrolytes, which was normal. Post-operatively, patient with continued with IV fluid and sedation, and amino vein was started.
It's amino vein में, amino VEIN.
I think.
Okay.
Yes.
And
Vaishali,
so
if I want to, if I, sorry ma'am, I'm interrupting.
no, it's
Vaishali, if I go on
Yes.
the immediate post of to this patient in NICU, and if I have to put one instruction on board for all my nurses, what would be that?
Uh, Meticulous handling of the infant's position, particularly of neck position.
What do surgeons insert?
Do not remove or change the feeding tube.
Absolutely. That's the most vital advice you should give to all of your unit care handlers, so that that particular infant feeding tube which has been inserted by surgeon should not remove, otherwise it will lead to many complications.
Yes.
So that takes us to the complications. Tell us some short-term complications and long-term complications seen in a patient with operated case of tracheoesophageal fistula.
Immediately, there can be anastomotic leak, which can be can lead to pneumothorax also in the short-term complications. Uh, in the long-term complications, there can be esophageal strictures, tracheomalacia, recurrence of the fistula. Uh, there can be gastroesophageal reflux. Uh, then over the long term, due to GER, there might be due to recurrent reflux, they can lead to dysplastic changes also in this.
Anastomotic leak
Commonest
will
long-term,
present as, what do you see? When would you know this is anastomotic leak?
We can see saliva in the drain.
Okay. What do you think? Where is the drain tip kept?
Can be in the pleural space.
Pleural space?
Uh, usual, Usually it is approached through extra pleural approach.
Where
So
is the tip?
usually uh, tip near the anastomosis in the
Absolutely. Okay.
extra pleural space.
Yes. Proceed.
so what are the three long-term complications or three things to be looked up in a patient who is following up with you after a post-operative tracheoesophageal fistula?
One is gastroesophageal reflux. It can
Very
lead to
true.
recurrent aspiration pneumonia. Uh,
Very
then
likely.
there is uh, esophageal atresia. It can also add up to
One last thing is stenosis, which can occur, which is a possibility here,
sorry,
because when the segments are very stringent or at distance, they have to pull it and give an anastomosis. So ultimately, on long term, there are likelihood of stenosis. And the most last thing or the most remote possibility is of this baby getting a hyperreactive airway disease on long term.
Yes. Uh, on the sixth day of life, there was deterioration in the baby's condition, form of increased oxygen requirement, worsening respiratory distress, and increased errantry on the right side of the chest. X-ray was done, which showed haziness on the right side of the chest, the right lung. So we did lung ultrasound, which suggested pleural effusion.
Was the feed initiated?
No, ma'am, not here.
Okay.
So for draining the effusion, second ICD was inserted on the right side in the pleural space, as the first was not draining. So here is the lung ultrasound of the patient showing pleural effusion.
What do you think is the reason for pleural effusion here?
It can be, ma'am, if there is
Quick.
pneumonia.
Just name it quick.
It can be post-operative chylothorax if the thoracic duct has been injured during the process. It can be um, para along with pneumonia, diffusion. if there is malposition of the central line, it can also lead to effusion.
Okay. So how would you differentiate each of these from each other?
Chylothorax will show the chyle, that is milky fluid in the ICD train. The will do we judge the clinically and do lab workup, and we can go for fluid analysis also.
Okay. What about pneumonia, pneumonic effusion?
In that also we can
Macroscopically, it wouldn't be white, right? Chylothorax,
yes,
unless you start feeds, will not manifest, will not be massive. So just check. I mean, the chylothorax appears, chylous ascites appears once you start feeding,
yes, ma'am.
right? So without, yes, tell me.
In the when the baby is not on feeding, or baby is matlab patient is on fasting, it can be clear or yellow
Absolutely.
color, as there
Correct.
is low content of fat and protein at that time.
Correct. Okay. Good. Yeah. What was your plan of extubation in this patient? Now, this patient was ventilated for 6 days. Why? As a unit protocol or
Initially, post-operative, as a part of as a post-operative care, there might be post surgically, as there might be tension between the two ends.
so what is the
Uh,
protocol of extubation in post-op case of esophageal atresia?
usually, ma'am, 24 to 48 hours, we go for it.
Okay. And this baby was ventilated for 6 days.
Yes,
Any reason?
was operated on third day of life. And as patient developed complications.
Okay. Proceed.
As the patient improved, uh, then ventilator settings were changed over to SIMP with FI2 of 21, PIP of 18, PIP of 5, I time of 0.4, and rate of 40. Post ICD insertion X-ray showed the pleural effusion reduced significantly or drained out. As draining fluid was clear yellow color, non-hemorrhagic, in quite significant amount. So fluid analysis was sent, as we were also suspecting the chylothorax, which showed the total cells of 130, polymorphs of 17, neutrophil of 30. Protein was less than 0.2, glucose less than 2. There was no pus cell. We also did pleural fluid triglycerides, which was 9. Gram staining showed no organism and culture was negative.
So this was chylothorax or this is transudative fluid
No, ma'am,
or
this can be
exudative fluid?
transudative fluid. Chylothorax should have at least triglyceride of more than 110.
So transudative or exudative?
With transudative, ma'am.
With cell count, such a high cell count?
Uh, Exudative fluids, ma'am, even more cell count and protein content also there is higher in the exudative.
Okay. Okay.
So, for the effusion, conservative approach was followed with replacement of the ICD output with normal saline 6RD. Meanwhile, the ICD output from the pleural effusion drainage gradually decreased and stopped. On the 8th day of life, patient developed increased work of breathing with decrease at entry bilaterally. So, and also simultaneously, ventilatory requirement also increased up to FI2 of 100, PIP of 22, PEEP of 5, rate of 40, and I time of 0.4. In suspicion of the pneumothorax, for this acute deterioration, lung ultrasound was done. So here we can see the ultrasound images of the lung. First is the video.
Clinically, how do we diagnose pneumothorax? We don't have, so I don't have lung ultrasonography. I don't have X-ray machine with me. How do I know that the baby has pneumothorax?
There can be sudden onset of desaturation. If there is tense pneumothorax, there can be uh, bradycardia, fall in the blood pressure,
No.
air, air
So that's very
entry.
advanced stage, no? Yeah. Please tell me clinically. Yeah.
There can be increased oxygen requirement, decreased air entry in the affected site.
And? And?
We can use the fiber optic cold light.
Cold light. What will
स्टेथोस्कोप
happen?
होता है
There will
डॉक्टर के पास?
there will be bright illumination.
Vaishali, what? Vaishali, Shah sir क्या बोल रहे हैं?
Yes, sir.
Vaishali, simple little stethoscope haven't you used?
Yes, sir. Decrease air entry.
Yeah, decrease air entry on particular side. Then
Yes,
you have
affected.
got the
Shift.
cold light source. You can use
So cold
vein
light.
finder.
Yes. So cold light source, how does cold light source tell you that this is pneumothorax, Vaishali?
So when we see a bright illumination, uh, if the air is present in the pleural
Compared
space,
to?
compared to the normal size.
Yes. Okay. Okay. So sonography is okay, but clinically we should have a suspicion. Okay. Or we should be able to diagnose pneumothorax. And what would be the emergency treatment then in that case if it is pneumothorax?
Then we can do the needle evacuation.
Oh, needle drainage. Okay.
Yes, ma'am.
Next.
So needle aspiration was done on both sides, followed by I3 insertion. So
What do
right
you think
sided,
this baby had bilateral pleural reason?
uh,
Bilateral pneumothorax
when
out of blue.
post-operatively anastomotic leak and ventilation are restricted.
Oh, okay.
Needle aspiration was done on the both side, followed by I3 insertion. Right-sided I3 was repositioned to drain the pneumothorax, and third ICD was inserted on the left side. So post I3 insertion X-ray. ABG was showing pH of 7.4, PO2 of 73, CO2 of 30, bicarb of 18.6, base excess of -1.8, which may suggestive of respiratory alkalosis. So, if this for this stabilization, then was settings were changed over to SIMD, FR2 of 21, PIP of 18, PEEP of 5, rate of 30, and I time of 1.
Next.
Two ICDs draining pneumothorax was clamped and removed over next 2 days. On the 9th day, dye study was done, which showed no leak. So patient was started with minimal fluids and they gradually increased. UVC was removed. Tip was sent for the culture. It showed no growth. Initial ICD drain was also clamped and removed on the 10th day of life. Patient was extubated on the 11th day of life. Patient was able to maintain saturation on room air without any distress. Breastfeeding was started as the patient accepted feed spell, was discharged on 16th day of life. Total antibiotics given for 7 days. Blood culture.
What is your discharge follow-up advice?
On the discharge, will advise to at the time of feeding, keep the baby in the slightly head up position. We will explain the danger signs. If there is any signs of aspiration, like a baby becoming blue, or if there is increased coughing, or there is increased retraction, then the immediate
Tell me the discharge. what medicines would you write on discharge paper of this baby? Thank you.
If the baby
Only
has
just name the medicines. Just name them. Don't explain why. Just name the medicines. What is the baby's weight at the time of discharge?
uh, at the time of discharge was baby weight was ma'am 2.60.
Okay, just name. These are the medicines I will give. One.
We can give H2 blockers if
Okay.
there is
H2
current
proton
reflux.
pump inhibitors. Okay. One.
Uh, then routine nutritional.
No,
Uh,
no. I name the medicines. One is you said proton PPI. Second.
we can give metoclopramide as a prokinetic agent. It will
Okay.
also help
Third.
with um vitamin D3.
Fourth.
Domperidone to prevent vomiting.
You want to give metoclopramide as well as domperidone.
No, no.
What do you want to give? Metoclopramide or domperidone? Or both?
Metoclopramide.
You have discharged this baby, right?
Yes, ma'am.
So you tell me the prescription. So you would give supplements, no? Calcium, preterm hai baby.
Yes, ma'am.
Iron to be started after some time.
Yes.
Proton pump inhibitors because baby is at risk of reflux, correct?
Yes, ma'am.
Follow-up advice. Which screening would you advise in this particular patient? One. Only just name the screening.
ROP examination, ma'am.
When? When?
Uh,
First screen when?
4 weeks.
4 weeks? After 4 weeks?
Birth, मतलब 4 week of birth.
हाँ, तो 4 week हो गया उसके बाद करना है
No, ma'am. At the 4 week.
before or at, not beyond. Okay?
Yes. At
Okay. ROP screening. What else? Any other screen?
hearing screening.
When?
It's also we can after discharge we can go for screening.
When? Immediately after discharge? Which
Yes.
screening are you talking about?
OE screening, ma'am.
OA. Any other screening you want to do apart from OA or only OA is okay with this case?
We can go for definitive BERA.
Definitive BERA. Go for means you want to do it or
Yes, ma'am.
option, patient को option देंगे?
No, ma'am. We'll go for BERA.
Compulsory BERA. When?
At 3 months of after
Okay,
3 months.
before 3 months. Okay, and obviously not beyond 6 months. Okay.
Yes.
What else?
Uh, developmental monitoring of it.
Okay, what else? Any particular to this case, you would screen the baby? You would monitor this baby for? Sir spoke about complications, no?
Yes, ma'am. Overall growth monitoring of the baby, ma'am.
Which growth chart?
We can use intergrowth.
We can, or you would use intergrowth,
Intergrowth,
right?
ma'am. Yes.
Okay. For complications, as sir mentioned, how would you monitor this baby for complication apart from growth chart? Okay. As per SPEGM criteria, scopy, endoscopy is advised in these patients, esophageal scopy, okay? To rule out Barrett's esophagus because they have reflux.
Okay.
Okay. And for how long you will give proton pump inhibitors in this case? 1 month, 2 months, 3 months, 4 months? कि मुझे लगता है तब तक.
If the baby has no more the symptoms of the reflux or recurrent coughing or
But
vomiting.
minimum 1 year they need PPA. Okay. Any question? Any other question?
No, I think it's very well going on. Whether the time is permissible now because we have crossed 4 o'clock.
But I would want to ask one question. Actually, this is esophageal atresia. But Vaishali, last question. When would you go for primary anastomosis and when would you go for secondary anastomosis? And if you go for secondary anastomosis, when would be the revision, when surgery would be revised again? Just last
Uh,
question from my side.
Okay, well, when if the baby is premature and not well, the baby's the preoperative condition is not permissible for the a low birth weight, then we can go for delayed primary closure. In those cases, if needed, we can go for the feeding gastrostomy and matlab make the baby better candidate for
No, I didn't understand. Tell me, if you don't go for primary anastomosis, what is the other way?
delayed primary closure.
What is done
Uh,
in that?
Initially, if the baby is extreme preterm and low birth weight, we can go initially we can ligate the fistula, just that is stage repair. Actually, we can initially just divide and ligate the fistula to prevent recurrent aspirations, and
And
simultaneously do gastrostomy to provide feeding and let the baby grow and be better candidate for
so,
the fistula, uh, the second repair later.
okay, so two things, Vaishali. It's not only ligation, it is cervical esophagostomy. Okay, and gastrostomy. Okay, and it is not only premature. Okay, sometimes it is on table decision when the gap between the two ends is long.
Yes, ma'am.
Okay, for preterm it is more than 2.5 centimeter, otherwise it is more than 4 centimeter.
Mm.
Okay, then they take a call whether it should be primary anastomosis or they should go for the delayed repair. Okay, yeah. Sir, I think that's it. Shah, sir, any question from your
Yes,
side?
yes, ma'am. And then it's very vital point that it's usually the on-table decision of those two segment gap which decides the further whether the procedure will go on with just a feeding gastrotomy or whether the end-to-end anastomosis will be taking place. So often this call is taken by our pediatric surgeons.
Yes.
So over to Kunal, I think.
Well done, Vaishali.
Thank you, ma'am.
Yes, Vaisali, we may be harsh to you in some questions, but I think this is not a postgraduate examination. This is for a fellow, so a level of question might be a little high. So don't feel bad about you or our questions. You are doing good. Please read more and be appeared. Best of luck to you for your fellowship exam.
Thank you, sir.
So thank you so much, everyone. Very well presented case by Dr. Vaishali. You have managed the patient very well. Of course, you've been mentored by an excellent Dr. Vishal. So thank you, Dr. Vishal, for excellently taking this case, and it was well presented. Thank you so much, Shilpa ma'am, for the wonderful questions and the brainstorming session. Thank you so much, Maulik sir. So you were very kind at the end. So thank you so much, sir. Thank you all. Shwetal ma'am, would you like to say something?
Very interesting case discussion. Thank you so much, both the expert faculties, for churning out our candidate. And so she can be prepared and she can do better in the fellowship exam. For Vaishali, I have one message. Excellent presentation, Vaishali.
Thank you.
What you need to do is you go back to this recording, which is available on the YouTube,
Yes, ma'am.
check each question and check the reasoning out, take out the references, and prepare yourself for 11th August. Best of luck.
Yes.
You will always be a student for us. So we are really very happy to see you on the platform of Neonatal Pathshala, and best wishes. Thank you so much, ma'am.
Thank you.
Thank you.
Well done, Vaishali.
Thank you, ma'am.
It was a good presentation and very well managed. Dr. Vishal, where is he? Left.
Thank you. Yeah.
I know this must have been very challenging bedside managing. She presented very nicely, but I could feel the adrenaline when she was presenting. Okay.
It's a
And thank you,
part of
Shweta
the
ma'am.
journey. Controlling your adrenalines and emotions is the part of the journey. You will always feel something or other, but ultimately remember that rocket goes up only because the back part of that rocket is burning.
Absolutely.
True.
True. Very true. Thank you, Dr. Shwetal and Kunal,
Thank you, ma'am.
for the
Thank you,
opportunity. It
ma'am.
was very nice.
Thank you,
Thank
Maulik
you,
sir.
sir.
Thank you so much, all of you. So now, with all your permission, I'm closing the session here for today. Thank you so much, everyone.
Thank you.